everybody, and welcome to Bethel Park's Live Well Speaker Series. My name is Chuck Stover. I'm the Recreation Director, and we do the series 6 times a year. Tonight's guest is Dr. Tracy Scanlon from Outreach Teen and Family Services. She will be talking about managing and coping with COVID-19. Dr. Scanlon?
Thank you. Thank you for having me, and I'm very excited to be here this evening to discuss with you the community at large and parents and caregivers specifically some of the issues around understanding how anxiety manifests in our kiddos and in our teenagers and in our young adults, especially during these, as everyone says, unprecedented times. So I would just like to first sort of lay some ground rules and let you know how the flow will go so that you know what to expect. I don't want us to get caught up in diagnosing or pathology or, psychobabble. What I really would like for you to be able to take away this evening is a better understanding essentially of what emotional wellness is, so that if you believe that your child is unwell, that you know what signs to look for, and that you might know where to reach out to, and that you might also understand the difference between a temporary normal flow of mood change versus something that is distinctly troubling and impairing your child. I'll share some statistics with you, and at the end of the presentation, I'd be happy to take your questions. But firstly, I want to start by reminding everyone that it's not a linear process, and this is not binary. So in other words, we are not looking at wellness versus sickness, and we are not looking at normal versus abnormal. There's a flow and a dynamic and a shift that occurs in mood and in thought and in behavior. Psychology is not just the study of emotions. It is the study of how emotions cause thoughts, which then result in behaviors. And primarily with children and teens and adolescents, you are going to be seeing behaviors that are probably indicators of something that's going on an emoting level or an internal level. But remember, there's an old saying from a theologian of the 13th century. His name was Occam. And in philosophical theory, there's something called the razor. In other words, it's that dilemma that people face when they're trying to solve a mathematical or scientific problem. And simply put, Occam's razor states that we should basically keep things simple. In other words, Occam's razor says, look for horses, not zebras. Meaning, you are going to see changes and transitions and mood liability in children and teens. But let's always start out by assuming that it's just part of their normal adaptation and a part of their normal development, and not look at every variance as a sign that something is distinctly wrong or abnormal or pathological. So I just thought I would like to start there so that we don't, cause too much anxiety if you hear or understand me saying something that you think you've seen in someone that you love, and it scares you or makes you feel uncomfortable. There are some statistics that I'll share with you, and there are some articles too that I'll leave you with that do explain that over the last decade, there has been a fairly significant increase in the diagnosing of anxiety-like disorders in children and in teens. It's an increase, but it's also a change. Up until about 15 years ago, depression was the #1 leading cause for a child or a teenager to enter counseling. It was essentially the #1 diagnosis that most kids in that age bracket received. But 10 years ago-ish, it turned and it became anxiety. And we have to look at that. We have to look at that as a micro group and as a macro group, as a culture, as a country, as a world. Why now, and why anxiety, and why the numbers? Why has it grown in the way that it has grown? Some statistics that I'll share with you, and I have those over here to keep in reference. As far as the anxiety disorders go, there are 5, and I don't want to get too far deep into the specifics about how you get diagnosed with one versus the other. But it's important to know a little bit about each one, and it's also important to know how prevalent they are, meaning how much you see them commonly occur in a specific group. And this evening, it's the group teens and children as it relates to what's going on during the pandemic or what you might be seeing as a result of that. About 20% of all children, so that's basically school age to young adulthood. In one given year, about 20% of all of the kids that you know probably fit the criteria for being diagnosed with something called a phobia. And you know that there's social phobias and there's specific phobias, but nonetheless, about 20%. About 10% of that is the social phobia kind. And I really think, and I know this from my clinical work at Outreach Teen and Family Services, that social anxiety seems to be on the rise, and it seems to be on the rise particularly with middle school aged boys and girls. And how it might relate to your everyday world is that teachers and administrators and social workers and parents are noticing that there is more than ever a tendency for school refusal. And that's not just, a child who is just refusing to go to school because they want to sleep in and, play Fortnite. It's an issue of children having such pent-up worry and fret that they can't find it within themselves to make it through the normal routine of getting up, getting on the bus, walking down those hallways, facing all of the triggers that provoke them. There's also about 7 or 8% of our kiddos that we see, and this is prevalent across the U.S., who struggle with separation anxiety. So sometimes the school refusal can have some of that in it too with the younger kids. About 5% of the kids nationally might fit the criteria for what is PTSD, which is post-traumatic stress disorder. And I know in the old days, we only knew about PTSD, well, at least as I was coming up and learning my craft, we only knew what we knew about it from the Vietnam veterans and those war heroes. But we know so much more now about trauma. And not all trauma is post-trauma, but all trauma has some things in common. And younger and younger children are experiencing episodes of traumatic loss and traumatic events in their lifetime. You might think to, mass violence as one of those, maybe cause and effect links, if you will. Losing a parent, not being able to go to school for 6 months during a pandemic might flag something in a certain kind of child with a certain kind of temperament. And generally across the population, about 2.5% of all of us meet the criteria for what's called GAD, which stands for Generalized Anxiety Disorder. And I think the best way to understand general anxiety disorder is to think of it in terms of nervous Nelly, worrywart. It's that person who, if this is what normal is, they run a little bit high, and everything causes them to stay high, and they don't necessarily know that they're escalated. It's just the way that they look at the world and interpret threat, essentially. I mean, that's what anxiety is. It's a misinterpretation, sometimes a misinterpretation of threat, perceived threat. But having said all that, it's important to know that all of us, generally speaking, those of us who consider ourselves high functioning and normal and not emotionally unwell, right? Not with a mental health disorder, so to speak. All of us have tendencies and behaviors and traits and things of that nature that manifest and sometimes make us a little more adaptable and a little less adaptable, and a little easier to deal with and a little less easy to deal with. But when we're talking about really diagnosing someone and looking at the criteria, we are looking at a couple of elements. Does this, let's just say this symptom in the room, or this symptom that this kiddo has, does this symptom cause personal distress? Whether or not a child can identify what the trigger is or the symptom is, does that child, does that teenager, does your college student seem personally distressed? And even if not, is there distress around that kiddo based on their symptom and other people are seeing it and experiencing it? It also has to do with functionality. It has to be looked at as not necessarily well. If a kiddo can't muster up the courage to get on the school bus in 4th grade for some reason, that means it's impairing this kiddo's functionality. It's getting in the way of their quality of life, and thusly they adapt in a dysfunctional way. So boiling it down, we all have our stuff, and we all have these little things that are kind of different from someone else, or quirky, as some people might call it. So we're not looking to diagnose everyone in the world, least of all the young people, but we do have to look at the gravity of the situation, the pronounced effect of the symptom, and how much that might interfere with the world around the child. Okay? How the bigwigs and super smart people do this is they use something called the Diagnostic Statistical Manual. If you don't know what that is, think of it in terms of what your PCP uses when they diagnose you with bronchitis. So there's a physician's desk reference, and there's a set of symptoms. And if you turn to a certain page and you look up those symptoms, then there's a diagnosis code for that particular set of symptoms. And that's all that the DSM does as it relates to emotional and thinking and cognitive symptoms or symptomatology. Generally speaking, anxiety, as I mentioned earlier, is categorized into 5, I'd say, the umbrella areas. So you have GAD, as I mentioned, so generalized anxiety disorder. You have OCD, which is obsessive compulsive disorder, which a lot of people think they know a lot about because it's a very common thing in popular culture and film and television. But you know, it's very different for those who suffer with it in real life. But you've got GAD and you've got OCD, and then there's panic disorder. There is post-traumatic stress disorder, and there can be, and of course there's PTSD. There also can be comorbid things happening. So someone with panic disorder might develop a phobia, probably agoraphobia, which is it's not just the fear of like walking outside of your house. It's a fear of being exposed. It's a fear of being outside of a safe place, and so the person's sort of quality of life shrinks because they need to stay in a place that's very safe. It's important also to note that not all stress, I mean, especially the stress that we've been under for the last 6 months, and I've seen this in my private practice over and over again, and I've seen it in the kiddos at Outreach. Some people integrate what's happening right now as stressful but manageable, and some as stressful and unmanageable. And generally speaking, we have to look at that in terms of 2 categories of stress. There's distress and there's eustress, EU stress. And distress is unpleasant and negative and everything you think you know about stress. It's generally what we call stress. But there's positive stress. That's the eustress. It's the planning of the wedding. Or the replanning of a wedding given the last 6 months. It is having a child. It is getting a home for the first time. Nonetheless, it's all stress. Some is ultimately going to result in something positive, and some of it is distress that we want to navigate swiftly and move away from. But we have to help our children discriminate between an upsetting, disruptive event and something that is just the course of the way that life goes. So the pandemic is grand, it is large scale, it is life-changing for everyone. So it is obviously seen as in the category of distressing. But you have had to have heard people along the way all these months talking about some of the things that have come out of the pandemic that have been, I don't know, a bit of a brighter spot, or what people would call a silver lining. What you want to be able to help young people do is stay away from the trap of seeing all stress as negative and as something we should get through and get away from as quickly as possible. What the research tells us is that children who experience low mood, so I want to be careful about using the word depression, but maybe mild depression, younger in life, are the young kids who are more likely, statistically more likely, to suffer with anxiety-related disorders as they age into adulthood. And part of that, I think, has to do with mismanaging the low mood. And I have this theory, this peanut butter and jelly theory. It's super scientific. And how I see it is you've got stress, you've got anxiety over here and depression over here. You've peanut butter and you've got jelly. And once you put them together, because they most often do commingle, and then you pull them back apart, you don't know which came first, and you no longer know which is which. Kids and teens, adults too, who suffer with low mood or depression for long periods of time develop adjunctive anxiety because they're worried that they're never going to rid themselves of the depression. People who have chronic anxiety and can't seem to manage it well often become depressed adjunctively because they are upset with themselves and down that they cannot make it go away, fix it, move on. So it's important to teach children early, at a very early age, how to problem solve, how to navigate unpleasant things, and really importantly, and I know it's very difficult, I am a parent myself and I understand the dilemma. It is really important to teach children how to grow their capacity for distress, grow their ability to sit with something unpleasant or scary and navigate it and think it through, and not just do that, that responding from your gut, responding from emotions kind of thing. As parents, I know, well, I'll accuse myself only and not everyone else, but I want to rush in, and I don't want my boy to have any distress. I don't want him to suffer on any level, and I want to make it all better, and I want him to go back to homeostasis, right? Like, I just want him to come from way up here where he is because someone was mean to him in school or something, and come down to his normal happy guy self. But those kids that we run in and rescue repeatedly are kids that don't develop frustration tolerance. And they're the adults that you don't want to be working with, and that you don't want to be neighbors with, and that you don't want to be living with, because they cannot adapt and manage triggers, irritability, and the unknown. So the earlier we start with kids about teaching them that some things are going to be stressful, they are not distressing on a large, grand scale, and that they can be navigated. And while doing that, allowing the child to develop their own coping strategies. It's called self-efficacy, and I love that word, and I probably toss it around a little bit too much, but really what efficacy is, and I just really think it's the root of so much that we can do to raise up our kiddos in a certain way, to launch them in a way that allows them to be, to believe that they've got what they need. Efficacy is just a self-belief that in a circumstance that we are not prepared for, we have the tools to navigate it. So in other words, something comes our way, we're not familiar with it, we've never dealt with it before, but we think, okay, I might have something in the toolbox for that. I can do this. So it's not just competency, which gets addressed a lot in academia, and it's not just confidence, which gets addressed a lot in athletics. It's somewhere in the middle. And if you don't have the efficacy, the confidence, and the competence, they're lesser than. So it's important that we teach everyone, that all of us understand that there are going to be triggers. Triggers are sometimes interpreted as a threat. And from childhood on through adulthood, we are going to always have some things that we adapt well to and patterns of maladaptive behavior. Think about the child that is avoidant about speaking up for him or herself to the bully. Think about the bullying child who is maladaptive because in the state of their threat and insecurity, they are aggressive and they are threatening. And that's just as sad and that's just as heavy as those being bullied are suffering with, as the symptoms that those are being bullied are suffering with. So we want to look at adaptation, we want to look at efficacy. And again, back to our friend the theologian Occam, we don't want to look at everything as pathological. I think a lot of the recent research in the past decade has pointed at, and I think to some degree it points at something that people want us to point at, that things are biochemical and it's chemistry and that it's organic. But in that assumption, the subtext is that, well, firstly, that if you have anxiety or you have depression, then it's a deficit, that you have something that you shouldn't have or don't have something else to replace it that you should have. So it's a huge deficit model. The other problem with that is, and I hear this from teens a lot and young adults, if we are trying to comfort them by saying that a certain kind of anxiety or mood is biochemical, we are suggesting, without necessarily being explicit, that it's a lifelong thing. There's a lot of times when people compare a major depression to diabetes. Well, if you were diabetic and you were suffering, you would take insulin. Well, yes, that's true. And that has zero to do with, it's apples and oranges, that has zero to do with major depression and how it gets treated and whether or not we're going to look at that as a chronic, unchangeable disorder for young people. I mean, that would be pretty heavy to hear that you have that diagnosis at 16 and having it explained to you in a way that suggests that you're signing on for a lifetime of this. So it has a lot of hopelessness attached to it, which I think also then has children being afraid or young people being afraid to even talk about it or ask for help or admit that something is amiss. So I want to talk to you a little bit about the 5 categories that I told you about for anxiety and just a tutorial, a 101. So again, worrying about anything and everything, if you see that kind of, I don't know, I wouldn't say conduct, but way of approaching the world in your child, you want to look at a lot of factors. You don't want to simply assume that they are always anxious or that they're worried. You have to look at temperament, the set of qualities that all of our babies are born with, that eventually, as they age into school, are considered traits of personality, and personality is pretty firmly, in place and not deeply changing, in young adulthood. But if you do experience someone around you who is a worrier, that's global worry, it's persistent worry. Probably what you're looking at there is a reason to address the worry, understand the narrative. If your child or your 16-year-old boy or your 21-year-old girl is consistently and chronically fretting, that tells you that they operate in the world with the idea that they are not necessarily safe. Now, I don't mean physically, but that they do not feel safe emotionally and psychologically, and that can be changed, that can be navigated, and it doesn't always need medicated. So I probably should have said that early on too. As a practicing psychologist, I'm not the person that prescribes, but I do believe in medication as an intervention, but I believe that it's a couple of stops down the road after a lot of other things get addressed firstly and get tried very early on. Secondly, we have what's considered panic or panic disorder. I think a lot of us talk about having panic attacks. I hear that a lot from young people. And I don't necessarily know that they are really having what are clinical, physiological panic attacks, but my point of view about that is if they feel panicked, then they are panicked, and then we treat it like panic. I mean, there's no reason to try to talk someone out of their feeling set about it. But what the problem with panic is, so as I explained to you earlier, if you have GAD over here and it's just someone that runs up a little bit higher anxiety-wise, panic is someone that's down here at the quote-unquote normal range and then has a spike and an episode and then comes back down and they stabilize and then has a spike and then an episode. And this can be very disconcerting. It absolutely feels like it, and it is a physiological response to stress. Any number of trips to the emergency room for what people believe are cardiac-related events can be explained by panic disorder, panic attacks. The heart races, the pupils dilate, the breath changes, the blood pressure skyrockets, people shake, people get vertigo. All of the very same kinds of chemical reactions are happening psychologically as physiologically. So it's to me a little bit more difficult for young people to navigate because, you know, they're sort of rolling along and doing their thing, and then there's a trigger or a certain person, place, or thing, or set of persons, places, and things, and it causes complete and utter upset. And that's why they talk about it in terms of attacks or sort of breakdowns. And oftentimes, you know, panic attacks are correlated to school refusal and social phobia and vice versa, and can be very, very difficult for parents and caregivers to navigate, especially with younger children. What has seemed to be the most successful along many, many years, several decades, is something called cognitive behavioral therapy. And I sort of have a little bit of a bad taste in my mouth with that because as a clinician, it's a little bit frustrating to have people call up, you know, answer the phone at outreach, and I'm ready to take the intake and talk to parents and, you know, find out how we can help them. And they say, I'm calling for CBT therapy, which isn't really a thing. Cognitive behavioral therapy is a technique that gets used in psychotherapy, which is talk therapy, which is counseling. So CBT is a technique that gets used and gets incorporated. And for young people whose prefrontal cortex are not developed yet, so when we say that they're immature and they're risk-taking and they're making a lot of stupid decisions, they are, and they're supposed to be, because their prefrontal cortex is where that's sort of where the judge lands, right? It's where that we develop in our mid-20s, that part of our brain that says, oh no, this is unwise to do this. But prior to that, it's still growing, it's still developing. And we've only really known that for about 50 or so years. I mean, we just assume kids age up, they get out of high school and they're grown up and they're adult. But so they're not being immature, they're being who they are, it's developmental. But knowing that parts of their brain have not developed fully, the reasoning part of the brain, CBT works especially well with younger people because it teaches very specific steps and things to do when something happens. So if A happens, do B. And if B doesn't work, try C. And so it's a sort of a concrete way of engaging a young person, which is sometimes necessary. I mean, a lot of 10-year-olds aren't going to necessarily want to be having talk therapy. So you want to have something that they can touch and know about and relate to and sort of put their hands on, if you will. And so it's particularly a good technique in psychotherapy for the anxiety disorders, for eating disorders, and also for the substance abuse disorders. So might be something that you might be interested in reading about and learning about, and because you can practice it at home. And it really is one of those things. If I'm doing CBT with someone, and lots of the therapists that work with me at Outreach use it all the time with younger folks, you can send home homework. You can practice how to respond to a trigger. So if your kiddo comes home and says there was something provoking or irritating or scary that happened to them, some of the CBT techniques can help you process it with them. And I explain CBT to people in very simple terms. So the cognitive part, obviously, right, is the thinking. So if you can change your thinking, you can change your feeling, which then changes the outcome. So if you think something, it makes you feel something. And the feeling is the thing that causes the behavior. So you can't just go after the feeling. You have to understand why someone thinks in a certain way. Are they pessimistic? Are they frightened? Whatever it is. You can't just go straight from feeling to, okay, now let's change the behavior. So it's thinking, feeling, acting. And that's a really concrete and relatively simple way to help children work their way through a situation that causes a thought that then brings on a feeling that causes them to respond in a certain way. And what you're looking at is trying to develop better ways of responding, healthier ways of responding. Secondly, we have phobias, which I mentioned before. There's specific phobias and social phobias. Specific phobias aren't really necessarily something that we need to be overly concerned about. It's the social phobia as it relates to children that I think, as I said earlier, ties into some of the behaviors that get them into trouble, and we're not recognizing that it's not just them refusing or denying something that we want them to do, but they're unable to do it out of fear. So a specific phobia is what you understand it to be. About 10% of the general population has a specific phobia. Probably one of the top three is the fear of public speaking, the fear of flying, the fear of small places. Okay? So what I do think is helpful for parents as we look at phobias, though, before we move on, is to understand that if your child is anxious and their tendency is to avoid or withdraw, and that makes sense, right? It's adapted. If you withdraw and if they stay home or they don't take many risks, they don't feel the triggers all the time. They don't feel the anxiety all the time. They don't feel the irrational gut sickness that people can feel. But it's a slippery slope. The social phobias can lead into social anxiety. Social anxiety on a grander scale can turn into agoraphobia. And then we have someone that is really in a very precarious and risky kind of mental state. We also have, in the 5 categories, as I mentioned earlier, post-traumatic stress disorder, which I think is something that maybe gets talked about wrongly a bit too much in our culture, or even the wording is tossed around a little bit loosely. It is the chronic and persistent experience of a trauma over and over and over again, long after that traumatic event, that disruptive event, that critical event occurred. So in other words, immediately following mass violence, we're Pittsburghers, right? So when we think about that, naturally my mind goes back to, the synagogue shooting in October of 18. That was a critical incident. It was a disruptive event. It was jarring to all of us, and children had to learn about it, know about it, and be exposed to it in the media. And it is an event that naturally is considered traumatic, and that a person having a traumatic response to is having a normal response to. But if 6 months later, or 12 months later, or 5 years later, the person is still experiencing that same level of response at the same velocity, then we're talking about post-trauma. If it's a response that occurs from the event up to 6 months later, it's considered acute stress disorder, meaning it's happening, it's in real time, it's being navigated, and it's pretty severe. But acute stress disorder is short-lived, if you will, and post-traumatic stress, responses to disasters and mass violence and attacks to your physical well-being or health, that can result in having long-term impacts on the way a person thinks, on the way a person integrates memory, and to the way a person learns. So this is especially risky with children, and something that has to be dealt with in a very specialized way, with people who have specialized training to work with children who have been exposed to trauma. There's something also called ACEs. It's the Adverse Childhood Experiences Inventory. And if you're like me and you get interested in this kind of stuff, I would Google it, and you'll find the ACEs inventory. And what it is it's an interesting self-report tool that asks you it's very short questionnaire that takes account for how you experienced your life. Were you a child that had enough food? Were you a child that knew you had safety? Was there at least one person around that could keep you safe? Did you witness violence? Did you live in an area where mass violence or community violence was prominent? All of these questions get asked in light of 50 or 60 years worth of research that tells us that kiddos who have chaotic, unpredictable lifestyles in early life tend to suffer more than the rest of us will. And so yes, poverty has to be factored into that, but I think some people forget that when I use the word chaotic childhood, there's all kinds of ways and all kinds of recipes for living in a chaotic way. And I think that does children in. I think it does all of us in. If we have a cluttered physical experience, we have a cluttered emotional experience. And kids that have gone through extremely adverse circumstances at an early age really have a pronounced increase in being diagnosed with mental health disorders, but even more than that, a shorter lifespan. You cannot separate what stress and trauma does to the physical body from what it does to the psychological mind. And so if a toll is being taken in both ways, the quality of life suffers, but so too does the quantity. So if you're interested in that, you might want to take a look at the ACEs inventory, Adverse Childhood Experiences Inventory. We also have the issue of obsessive compulsive disorder, which I have heard from some parents and some of the therapists that I work with might seem to be on the rise a little bit symptomatically among younger kids who were already anxious when the pandemic hit. And so you want to look for rituals. You want to look for kids doing things that seem somewhat abnormal, but when people have obsessive compulsive tendencies, really they know intellectually that the thing that they are doing, the ritual that they're performing, is irrational. But the ritual in and of itself makes them feel calmer and safe. So in some ways it's very hard to argue with someone that that's not adaptive. There are lots of studies that show us that people with OCD have an area of their brain that sort of gets overheated when they are traumatized or distressed, and so they get stuck, and that's where you see that sort of perseveration kind of thing occurring. OCD, school refusal, social phobia, panic issues in young people are sort of a dangerous conglomeration that can result in a child not being able to necessarily be in the classroom, in the average kind of school, in the average kind of way, without extra kinds of support. So you want to look for some of these kinds of behaviors that indicate to you that your child is a little bit more nervous and is using rituals to calm themselves. It's self-soothing. So again, in some ways, it's adaptive. About 5% of American children within the last 3 years, this study is from 2017, are listed in the category of school refusal. And it comes from that, well, it's like taxes. So either you have, it's money, either you have enough of what you need to pay the tax to take care of whatever you want, or you are depleted and what you need exceeds what you have. And that's stress. That's what happens to all of us. When something pushes us beyond our ability to cope, or at least our belief that we have the ability to cope. And sometimes that's why the behavior manifests as school refusal. That a child believes they do not have whatever it is that they believe they need, that taxes them so much that they no longer can get up and go to school, that it is profoundly distressing to them to even think about such a thing. That all has its roots in this combination of anxiety and panic and fretting. And it should also be noted that one's family mental health history factors in when we're looking at kids who struggle with certain symptoms. Not necessarily that that everyone who has a parent who has suffered with depression or had bouts of anxiety is going to pass it on to their children. There's that, people like to say things like, oh, it runs in the family. But I firmly believe that biology is not destiny. And so if something is running in some generation of some part of the family, then let's work on ridding ourselves of it for the next generation in that family. Schizophrenia, different. Bipolar, different. They're highly heritable, they're organic. We're talking about brain disorder issues in that. But generally speaking, biology isn't destiny, and there's lots that we can do to improve the quality of life for our kiddos. I wanted to share with you 2 articles that I think are really, really interesting and timely, and just share a couple of statistics as we wrap up. One of the articles that are shared in the slides that you're able to see has to do with this issue of why anxiety more than depression, why anxiety more than depression now, and why young people. And there's lots of really great data in there and great information that's very user-friendly. But one of the things that are noted in the article that I think are important to pay attention to are some of the statistics. So in the 80s, about 20% of kids were diagnosable with anxiety. By 2010, it was almost 30. And now we're at over 40% in 2020. So we have to look at lifestyle, we have to look at social media, we have to look at parenting styles, we have to look at chemicals, we have to look at so much. But it's important when you're seeing prevalence rates drive up that significantly to look at solutions and ways to address it. The other article that I shared in the slides is talks about the kids not being all right. And I think our kids are more all right than we think they are, but don't fall for the same old marketing plea and things that people like to say that kids are resilient and kids can handle it and kids get over it. Some do, and some are resilient, but some are more resilient than others, and some things are not about resilience. And so I think we have to be careful about that. But you'll note in the slide about from the Department of Human Services that 12 to 17-year-olds are really a group of a cohort of kiddos who suffer pretty greatly with the diagnosis of depression. So in any given year, up to 3 million of our tweens and teens meet the criteria for having a depressive episode within the last 12 months. And post-pandemic, I think we want to be looking at it. I think we want to be looking at what's going to happen in a year. You may not see everything the emotional toll right now, but you have to watch for it as we move on. And of course, teachers, social workers, parents, nurses, they recognize this because they're on the front lines, right? They know that, they see the kiddo coming in the room and sort of wearing the symptoms. And so my best advice as a clinician, but also as a mom, would be to pay attention. Pay attention without panic. Keep it simple. Look for signs, but don't assume that normal ups and downs or flows and adjustments in adolescence are a sign of something detrimental. The key is very simple. Have open lines of communication. Ask questions. Be the one that they can say anything to. And if you can't be that one, get them a good therapist. Send them to their favorite sibling. Get the perfect aunt that they all love. Anyone, just have someone. Every kiddo, it's ideal if they had a great all-American, whatever that is, normal, 2 parents, 2.5 kids, picket fence, dog, something of that nature. But it really only takes being tethered to one adult who's safe that will result in a child being able to grow and develop and stay healthy. So I thank you for your time, and I welcome your questions. And I would be happy to take your calls or emails at Outreach Teen and Family Services at any time if you have any questions or would like to do a parenting consult. Thank you.
Thank you, Dr. Scanlon. That was quite interesting.
Thank you.
I'll start off the questions. Is there anything we can do as just individuals, exercise, eating better, or anything to help manage our anxiety and mental well-being, our mental health?
Yeah, I think it's an overall approach, right? It's holistic. We want to look at what you're fueling your body with, and importantly also is sleep hygiene, which I think people take for granted. And a lot of these routines, right? People do well. The human animal does well with routine. What was the first thing that went out the window last March? Routine. That's mealtime, normal meals, sleeping, waking. I would say as far as physical wellness to serve our emotional wellness, other than, of course, trying to fuel our bodies with good food, healthy food, it's looking at how we sleep and making sure that we're pretty ritualistic about keeping a sleep hygiene schedule. No screens an hour before bed at least, dark room, cold room. The only thing you should be doing in there is sleeping when you're ready to go to sleep, and that's where you go, and keeping pretty ritualistic about that.
Okay. Is there any advice you can give the parents right now just to, before their kids get too anxious?
Well, I think with the start of school, right, and the transition back, however back is, if it's the hybrid or you're in the building, you're not in the building, you're homeschooling, everyone's changed their schedules. I mean, it's an upside down process at the moment, and everybody is struggling. And I think that children respond to honesty and to knowing that we don't necessarily know all the answers either, and that we're figuring it out as we go, and that we're doing that collaboratively. I don't understand new math, for example, so I tell my son that I don't understand new math, and we get help, and we ask people, and we try to keep the frustration level low between the two of us. It creates such an unhappy dynamic if you don't. So I think the best advice is to be honest, and that's always going to be based on a child's age. So I'm not, you don't talk about detailed, intellectual, complex thinking and problem solving with young children, but you can be honest about what you know and what you don't know, and what your own strengths are and what your own weaknesses are, and children relate to that. That also helps develop empathy in a young child, and that's an incredible quality.
How do we get back to normal mentally? How do we get back to normal? This is such an unprecedented time.
Right.
We're talking about the new normal, the new this. How do we get back to just normal?
Yeah, that's a burning question, right? And of course, I think people are actually burning out on the phrase new normal. you know, I work a lot with folks with trauma, and trauma can be complicated by grief or brought on by grief or things of that nature. And what bereft people have often said to me is that they detest when people tell them, in order to comfort them, that they just have to develop a new normal after having lost their husband or their spouse or their mom or something of that nature. You know, it gets to be cliche. So I think the more meaningful thing for folks is to realize that we are already living a normal that we haven't lived before, and it's different, and we're still figuring it out, and it's unfolding, and it's dynamic. It's not either there's the old way, like the old math, or the new way, like the new math. It is that as we develop, as we learn and gather data, and life changes around us in grand ways based on the pandemic, that we are normalizing as we go. It's not that we're going to get to normal. It's that it's occurring dynamically, constantly as we go. And sometimes we feel more in control and sometimes less in control. So to me, it's far less about deciding that things are normal again than it is to say, I feel like I have what I need in order to organize my life in a way that's meaningful and makes sense to me. And that's what we need to help children do as well.
And that's a difficult process, especially young children. You talked about loss before and losing a parent young. I lost my mom very young, and it is difficult as a child to process that.
I know.
And back then you didn't talk about it. You just marched on. And at times in your life when you're older, it bugs you because I didn't learn and grow from that experience. You know, you're sheltered and protected. Everyone wanted to protect you.
It's interesting. I think the same thing that is that one of those like old people things to say that back in the day we didn't do that or something? But it feels so different today. There's so many more resources and places and specialties for kids to access when they've lost a mom or a dad, because that is a traumatic event. But what traumatizes the child and may ultimately alter the way they think and feel about the world is the response that people have to what happened to them, or the lack of response that people have. And these days, there's just no reason not to wrap around that child or those children because there's so much available. And I don't know, is it just, American bootstrap theory that back in the day, everybody just picked themselves up and dusted themselves off and moved on. But for kids, having not had the time or the chance to process that in sort of a righteous way, to know that it was okay, that it felt like it was destroying, that's really cheating them.
It is. We do have a question. How do you keep the tendencies of the children that started during COVID to get away from them after we get through this pandemic?
Well, I think we saw that a lot, right? I think that we saw that at the very beginning when there was this idea that, we're not going to go to school for a few weeks, and it's going to be like a mini vacation, and so it's like Christmas break, right? We can stay up late, and we don't have to do as much work and all of those sorts of things. And then, of course, it's dragged on and dragged on and dragged on, and then we've developed new tendencies. And I just look at it as an issue of scheduling and routine and organization. I mean, we transition every August into what back to school is going to look like, and the sports that come with it and the academics that come with it. And then we all look forward to the transition into the holiday season, which gives us a little bit of a break. And then we have to rev back up in January and hunker down and do all kinds of other things that we weren't doing for a while. This, yes, is on a much larger scale, and it is happening globally. So it's not to say that that's going to be easy, but it is not something necessarily all that new to us. Parents of younger children often have to moderate and oversee and facilitate transition, routine, and movement. And this is just happening to us in an unexpected way, from an unexpected source, but it's not something we haven't done pretty much all of the life of a child if you're parenting them in a certain way. I think the other thing is that you tell the child that, you know, this is the way we're going to do it now. It's okay to do that. It's okay to say, yes, we did it this way because of X, Y, Z. And now it's a new time and another day, and school is back in session, and we're going to organize ourselves differently. And you're going to get resistance. And it's going to be hard. But that's the nature of the healthy child, to rebuff and to push back. That's not necessarily unhealthy at all.
Is there anything that parents of kids start to hit teenage years when they're going through all the physical changes should look for during this time? Because, you know, their minds aren't as developed as they should be, and all of a sudden they're going through all the physical changes too.
Right, right. What I think is important to note for, you know, parents of tweens and teens, right, is that we are looking at significant changes in hormones. And I mean, people want to talk about that in terms of like the human sexuality aspect, but neurohormones affect mood and sleep and appetite, not just, you know, the growing sexuality of the young teen or tween. So be careful that you don't see those shifts and those changes as necessarily, you know, psychological or psychologically distressing, or signs of emotional distress. You know, irritability, that goes with the territory. Moodiness, that goes with the territory. You know, the changes in sleep, the changes in motivation, it's frustrating and it can be infuriating, but the thing to remember is that if it is occurring and it is impeding the child's functionality or their ability to be successful, or you believe that they are suffering on some level, then you have to intervene, and simply intervene by asking questions and being willing to accept the honest answers. And then, you know, create a treatment plan, if you will, like decide what you want to do to address that issue. Lots of parents will call outreach and say that their teen has requested counseling. They want someone to talk to about what's going on because they know they're struggling, and they don't want to talk to mom about that. They don't want to talk to dad about that. And that's a great thing. I'm so enthusiastic when the child or the teenager notes that themselves and recognizes they want to get some support. So be willing to do that too.
Okay, thank you, Dr. Scanlon.
Yeah, my pleasure.
On behalf of the municipality, I'd like to thank you for being our guest speaker tonight. And I'd like to remind everybody else, our next guest speaker will be Dr. Tim Campbell on the obesity crisis. And that'll be on October 21st. Thank you very much for joining us tonight. Thank you, Doctor.
Thank you.